Hello everybody, thanks for tuning into this exciting PowerPoint presentation. We're going to be going over the ECG rhythm interpretation refresher. A little disclaimer, this is a refresher, so if this is your first time ever learning about ECG interpretation, I do not recommend you watch this video. Instead, I would recommend you take a full-length class. This class does omit a lot of anatomy and physiology, and I find that you would benefit more from a full-on class. Two objectives for this class are going to be use a systematic process when approaching the interpretation of the ECG. A lot of times when people are looking at rhythms, they jump to conclusions of what it could and can't be. In those situations, I always recommend that somebody takes a step back and uses the 5-step method to decipher what they're looking at. The second objective is going to be that the learner will be able to identify normal and abnormal components of the ECG. We will cover the lead placement for the 5 lead, which is what we're going to see in a lot of the bedside monitoring. So the RA lead goes over, the white lead goes over the right shoulder. And then on the opposite side, you would put the black lead, otherwise known as the left. V1, or the brown lead, goes where V1 for a 12 lead EKG would go. It's going to be the second intercostal space, right of the sternum. Then we've got the left lower, which is red, and the right lower, which is green. A lot of people will say, can it go on the arms or can it go on the chest? I would say to minimize artifact and movement, put it on the chest. Either choice is appropriate as long as they are matching. So don't put the left one on the arm and the right one on the chest. Just ensure that they are symmetrical. At first glance, the components of the ECG can be a little bit overwhelming, but if you break it down, particularly when you're looking at this slide here, you'll see that there's a PR segment. There's a PR interval, QRS complex, QT interval, ST segment. While those are important for measuring different conditions, remember that the most basic parts of an ECG are going to be the P wave, the QRS complex, and the T wave. So the ECG waveform and mechanical representation. The P wave, as we remember, is our atrial depolarization or contraction. So when you see that little bump, the P wave, that's telling you that that impulse is coming from the atria, and it's your intrinsic, your natural pacemaker. So anything that doesn't have a P wave is not going to be sinus in nature. You have your QRS complex. This represents ventricular depolarization, and you don't see it, but at the same time, atrial repolarization is occurring within that. What you see on an ECG is the net energy output. So that QRS is going to be a lot stronger. It's going to have a lot more electricity than that atrial repolarization. So we're only going to see that QRS complex. And our T wave. T wave represents ventricular repolarization, or the resting phase. As we remember, our x-axis is going to be a representation of time, while our y-axis, or vertical up and down, is going to be a representation of voltage or electricity, called the amplitude of that waveform. Reading the ECG graph paper, the ECG graph paper has these small tiny boxes, and you see these across the entire paper. Each one of these small tiny boxes is representative of 0.04 seconds on the x-axis, and then if you get 5 of them along the line 1, 2, 3, 4, 5, that is 0.2 seconds in time. And if you were to get 5 of these big squares in a row, 1, 2, 3, 4, 5, that is representative of 1 second. Interpreting EKG rhythm strips, read every strip from left to right, starting at the beginning of the strip. Apply the 5-step systematic approach that you will learn in this module for consistency with each strip that you interpret. A lot of times people will look at a rhythm and be overwhelmed with the amount of things they're seeing on there and try to interpret it based off of memory. But if we learn the 5-step process, we can work our way through deciphering what that rhythm is. Interpreting ECG, the five-step approach. The five-step approach in order of application includes analysis of the heart rate, and that's going to be, is it less than 60? Is it between 60 and 100? Is it greater than 100? Is it greater than 150? This is important to know which direction you're going to go, and it's the first step. The second step is the heart rhythm. Is this regular or is this irregular? Step 3 is the P wave. Does every single QRS complex have a P wave? Is that P wave uniform? Where is it in relation to the QRS? Is it close? Is it far? Step 4 is the PR interval. How long is that? This goes back to the P wave. And a lot of times, in some instances rather, you won't have a P wave, so you will not be able to interpret the size of that PR interval. And number 5, the QRS complex. Is it wide? Is it narrow? Is it there? Does it look just like the other QRS complexes? These are all different things that you're going to be asking yourself while figuring out the five-step approach. Methods to determine heart rate. The 6-second method denotes a 6-second interval on the ECG strip. The strip is marked by 3 or 6-second tick marks on the top or on the bottom of the graph paper. In this case, you would count the number of complexes occurring within that 6-second interval, and then you multiply that by 10. For testing purposes, we are going to assume that the strips you're looking at are 6-second strips. And it's just an estimate. It's never going to tell you the heart rate is 55 because you're multiplying by 10. This would either be 50 or 60 or 70 or 80, etc., etc. There's a backup method called using the rate determination chart. We'll touch on that in the next couple of slides. The 6-second method to count strips, you would look at these lines here, these tick marks here, here, and here. These are notating that the time between here is 3 seconds, and this is 3 seconds, so together it gives you 6 seconds. In order to make this calculation, you would count how many QRS complexes are within these tick marks here. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 10 would give us 110 beats per minute. If you found yourself having to count the rate by using the rate determination chart, you would count the spaces between R to R complexes. And in order to do that, you would need to know that the space between this line and that line is 0.2 seconds, and 5 of these, 1, 2, 3, 4, 5, that is 1 second in time. So if a QRS complex were to fall on this line and the next QRS complex were to fall on this line, you'd be looking at a rate of 300. If the first QRS complex fell here and the next one was here, that's 150. And if it was here and here, that's 100, and so on and so forth. There is this chart here for your reference. We find that not everybody has this in their pocket and ready to make this calculation. This is why the 6-second method is preferred. So, using that method again, we're going to count that there are 25 small boxes from this to this, or you can remember that within each one of these large boxes is 5. So we'll count 5, 10, 15, 20, 25. We've got 25 small boxes or 5 large boxes from R to R complex to give us a total of 60 beats per minute. All right, so that covered step 1, determining your rate. Moving on to step 2, we have rhythm interpretation. And this is just, is it regular or is it irregular? Rhythm is defined as a sequential beating of the heart as a result of generation of electrical impulses, classified as a regular pattern. The interval between the R waves is regular, or an irregular pattern. The interval between the R waves is not regular. A regular rhythm, measuring a regular rhythm, measure the intervals between the R wave, measure from R to R. the intervals vary by less than 0.06 seconds or 1.5 small boxes, the rhythm is considered to be regular. If in your test you're being provided with calipers or some kind of measuring device, you would get a number from here to here, and then you'd move it to a different set of complexes further down the strip, and if that space is equal, you can consider that that rhythm is regular. If you have different distances from R to R, you can consider that to be irregular, such as this one right here. Measuring an irregular rhythm if the intervals between the R waves from R to R are variable by greater than 0.06 seconds or 1.5 small boxes, the rhythm is considered to be irregular. With the trained eye, you can see that a lot of these QRS complexes vary in distances pretty frequently, and just from my experience, knowing how irregular this rhythm is and the absence of discernible P waves, I would say that this is a AFib, rapid AFib, or AFib RVR. Step number 3 would be your P wave analysis. The P wave is produced when the left and right atria depolarize. The first deviation from the isoelectric line, our isoelectric line is going to be that line that's about average and the rest of the ECG is just resting at. Or if you would consider asystole just being just the isoelectric line, there's no other activities. So if they're not in asystole, then you can see that they've got activity with the energy depolarizing and repolarizing. Should be rounded and upright. The P wave in a normal state will be rounded and upright. The P wave is the SA node pacing or firing at regular intervals. This pattern is referred to as a sinus rhythm, sinoatrial. It's coming from the sinus, the atria. And then in that step, the P wave analysis, there's 5 additional questions to ask yourself. Are P waves present? Then, are P waves occurring regularly? If there are 1 P wave present for every QRS complex, are the P waves smooth, rounded, and upright in appearance, or are they inverted? Do all P waves look similar? All these questions do have a purpose. Step 4 is to measure your PR interval. Measures the time interval from the onset of atrial contraction to onset of ventricular contraction. Measured from onset of P wave to the onset of the QRS complex. Normal interval is 0.12 to 0.20 seconds, or 3 to 5 small squares. The PR interval. The PR interval, there's 3 questions to ask yourselves. Are the PR intervals greater than 0.2 seconds? Are the PR intervals less than 0.12 seconds? Are the PR intervals consistent across the EKG strip? The purple lines in this graph here on the QRS at the very beginning of the P and right where you go to the Q indicate where calipers should be placed to measure the PR interval. So take your calipers or measuring device or calculate the number of boxes from one line to the next line and you'll get your PR interval. And step 5, the QRS complexes. The QRS complex represents depolarization or contraction of the ventricles. The Q wave, the first negative or downward deflection of this large complex. The R wave is the first or positive deflection following the P wave, or the tallest waveform, and the S wave, the sharp negative or downward deflection that follows the R wave. The normal interval is 0.06 to 0.12 seconds, or 1.5 to 3 small boxes. And measuring the QRS, the purple lines on this graph indicate where the calipers should be placed to measure the QRS. QRS complex There's three questions to ask. Are the QRS complexes greater than 0.12 seconds in width? Are the QRS complexes less than 0.06 seconds in width? And are the QRS complexes similar in appearance across the EKG strip? So again, you're going to measure consistency with those QRS complexes by either taking your calipers or measuring how many boxes and comparing it to the other complexes on that strip. So these are a couple of examples of measuring QT intervals. And these are there for your reference. All right, so just to recap, we're gonna determine the heart rate by counting the number of boxes between the R's. In this case, there's 19 spaces in between. We'll look at our graph here and determine that this rate is 79. We can also count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then if we were to do 10 times 10, that'd give us 100. However, there's no way, there's no hash marks to determine that this is a 6-second strip. So our best way to interpret this would be by counting the number of boxes. The rhythm is from the R to R, looks pretty consistent across the board. So we would say that this rhythm is in fact regular. Are there P waves? The P waves are there. They look pretty uniform. They're upright. They're not inverted. And is there a QRS? Is there a P wave for every QRS? It appears that way. The PR interval measured from the beginning of the P to the QRS, so that looks pretty normal. And the QRS is the measure from start of the Q to the end of the S wave. So these QRS complexes look narrow, they're not wide or anything like that. So I would say that this is a normal sinus rhythm. All right, we'll touch on artifact. EKG waveforms from sources outside of the heart. So this can be like the patient moving or some kind of electrical interference. You know, if they have a cell phone or some kind of device that's putting out electrical noise, can have the potential to interfere with the ECG strip and its read. However, never assume that this is artifact off the at first glance. Always confirm that this patient is not, in this case, an AFib. I don't think they are. This definitely looks like a sinus rhythm with artifact. I do see P waves kind of there. I do see some T waves. There's a QRS. It's just really noisy per se. So maybe this patient's cold, shivering. Definitely check on your patient and make sure that you're replacing those leads or making them a little bit more comfortable so that we can have a better read. So again, to recap, those 4 possible causes of artifact can be patient movement, loose or defective electrodes, improper grounding, or a faulty EKG apparatus. Those will be the last things that you, equipment will be the last thing that you assume. But again, never assume that this is artifact without first checking to see if there's anything you can do to mitigate the noise. On this slide, we're going to be working through the normal sinus. In this case, what is the rate? Rate for a normal sinus is going to be anything between 60 and 100. Of course, anything under 60 is going to be bradycardia. Anything above 100 is going to be tachycardia. So that normal sinus rhythm is going to be between 60 and 100 beats per minute. The rhythm of a normal sinus rhythm is going to be regular, and atrially, those P waves are consistent, and the ventricular rhythm is also going to be regular. Those QRS complexes are going to be where they need to be regularly. Is there a P wave before each QRS? In this case, yes, there is one P wave to every QRS complex. Are the P waves upright and uniform? Yes, they are. And the PR interval, It appears to be normal. It's not prolonged. Is it between 0.12 and 0.2 seconds, or 3 to 5 small boxes? Yes. Do all QRS complexes look alike? Yes, they do. And what is the length of the QRS? It is normal. It is not wide or completely narrow. It is 0.06 to 0.12 seconds. There's no intervention required for a normal sinus rhythm. Continue to monitor per physician's orders. And of course, if this was in a cardiac arrest situation and you just got a rhythm, organized rhythm on the monitor again, you'd want to confirm a pulse. In this case, we're going over normal physiology. So normal sinus, assume there's a pulse, unless you're in a situation where you have to do ACLS. So touching back on the sinus Brady rhythm, this is sinus in nature. However, because its rate is less than 60 beats per minute, it's going to be considered sinus Brady. Let's look at the rhythm. The rhythm is it's regular. Their P waves are where they need to be, when they need to be there, and the ventricular rhythm also is pretty consistent. There's a P wave before each QRS. The P waves are upright and uniform. The PR interval is normal, 0.12 to 0.2 seconds, and all QRS complexes look alike. None of them are wide, bizarre, or aberrant. What is the length of the QRS? The length is 0.06 to 0.12 seconds. Sinus bradycardia is irregular, but unusually slow heartbeat, less than 60 beats per minute. Sinus bradycardia is often seen as normal variation in athletes during sleep or in response to a vagal maneuver. So if you ever take report from a nurse and it's not mentioned that the patient has been Brady the entire time, you might want to go in there and assess the patient for any changes. Moving on to sinus tachycardia, again, sinus in nature, it's coming from the atria. There are P waves. The rate is fast, and it's a sinus rhythm, but because it's greater than 100 beats per minute, so it's 101 to 150, we are looking at a sinus tachycardia here. It's regular in nature, both atrially and ventricularly. There is a P wave before each QRS complex. The P waves are upright and uniform. The PR interval and the QRS complexes look alike, and the length of the QRS is normal, so it's not wide and regular. We'd be looking at something completely different were that not the same, were that not true. Sinus tachycardia is a fast heartbeat related to a rapid firing of the sinoatrial node. The clinical dysrhythmia depends on the underlying cause. It may be normal depending on the patient. So if you're like me and you've had a coffee and a Monster, a lot of caffeine this morning, this might be, we can explain that I might be in a sinus tachycardia because I had caffeine. You might look at these patients that have fevers, maybe septic. You might have somebody that's hypotensive and tachycardic because they're bleeding out somewhere. So look to investigate why this patient might be in a sinus tach. It might be normal, it might be abnormal. Sinus arrhythmia. So looking at this, the rate is between 60 and 100 beats per minute. So it's not a bradycardia and it's not a tachycardia, but by looking at this, it is not a normal sinus rhythm. It is a sinus arrhythmia. So what makes this a sinus arrhythmia is the lack of it being regular. This, I can tell that from here to here is shorter distance than from here to here. Are there P waves for each QRS? Yeah, there are. So it is sinus in nature. Are the P waves upright and uniform? Yep, they look pretty much the same. And the PR interval is between 0.12 and 0.2 seconds. All QRS complexes look alike, and the length of the QRS is between 0.06 to 0.12 seconds. Sinus arrhythmia is a normal variation in the beating of your heart. A sinus arrhythmia refers to an irregular or disorganized heart rhythm. This rate usually increases with inspiration and decreases with expiration. Greater than 0.12 variation to the R to R. Some of you may be asking, why do we look to see if the P waves are uniform in nature? And that is because it can be a wandering pacemaker. So you can see that these P waves are they have different morphology. They're not very uniform. They don't look alike. So a wandering pacemaker would be when you have 3 or more distinct P wave shapes. Another indicator of the abnormal P wave would be something like a premature atrial contraction. So you have an extra beat that's causing another beat in the heart rhythm. And we'll see that here in a bit. We have the sinus arrest or sinus pause. This is going to be defined by a pause or absence of electrical activity for a period of greater than 3 seconds. So the rate is hard to determine because of the variability in this. Just depends on how many complexes you can see in what you determine to be a 6-second strip. The rhythm is irregular, especially because between here and here is not consistent as it is between here and here. Is there a P wave before each QRS? Yes. However, as long as there is a QRS present, are the P waves upright and uniform? Yep. Whenever there's a QRS complex, yep, there is a P to every QRS. And the PR interval is normal when there is a QRS complex. So the biggest thing we're looking at here is this 3-second pause. A sinus pause or arrest is defined as the transient absence of sinus P waves that last from 2 seconds to several minutes. Never assume that a lead came off. Never assume that this is just artifact. To ensure safety of your patient, ensure that if you see something like this, it's escalated appropriately. First, check on the patient, and if it's deemed to be an actual sinus arrest or pause, you escalate it appropriately. And if it's something that's due to equipment or the leads are off or something, address it and continue monitoring for that to reoccur. Atrial rhythms. Atrial rhythms, when the sinoatrial node fails to generate an impulse, atrial tissues or internodal pathways may initiate an impulse. The 4 most common atrial arrhythmias include atrial flutter, atrial fibrillation, supraventricular tachycardia, and premature atrial complexes. Atrial flutter. Not to be confused with atrial fibrillation, atrial flutter is most notably known for having this sawtooth pattern where the P waves would normally be. So you got these saws here. You'll notice that the QRS complexes are relatively normal. You would say that it looks like there's 3 P waves to 1 QRS complex. The atrial rate is between 250 to 400 beats per minute, while the ventricular rate may be variable. The rhythm, it's regular from the atrial perspective. Ventricularly, it may be irregular. There might be some variation between the QRS complexes. Is there a P wave before each QRS? Normal P waves are absent. These are called flutter waves or F waves, and they come in that sawtooth pattern. Therefore, the PR interval is not measurable. Do all QRS complexes look alike? Yes, for the most part. And the length of the QRS complex is normal between 0.06 seconds and 0.12 seconds. Atrial flutter is coordinated rapid beating of the atria. Atrial flutter is the second most common tachyarrhythmia. Atrial fibrillation, very common, can be normal, can be very abnormal, especially in our new onset patients. So what is the rate? The rate varies. You have an atrial rate of between 350 to 400. Ventricular, again, is variable. The QRS complexes are going to be irregular. Is there a P wave before each QRS? No. One of the things about AFib is that it has no discernible P waves. So it looks like a lot of bumps, but it could look like artifact. However, you cannot definitely say, yeah, that's a P wave. Are the P waves upright and uniform? Again, we can't make out what's a P wave. What is the PR interval? It's not measurable because you don't have a P wave. Do all QRS complexes look alike? Yes, they do. And they are, the length is consistent, 0.06 to 0.12 seconds. The electrical signal that circles uncoordinated through the muscles of the atria causes them to quiver without contracting. The ventricles do not receive the regular impulses and contract out of rhythm, and the heartbeat becomes uncontrolled and irregular. So this is one of our can be one of our primary causes of emboluses throughout the body, causes strokes. So the patient does not have a history of AFib and they're symptomatic, definitely escalate this. Ensure that it is controlled and they're not having any other symptoms or complications of this AFib. All right, so one of our most exciting rhythms we encounter in the emergency department is going to be the supraventricular tachycardia. This again, it does not have our classic P waves that are discernible on the rhythm strip. The rate atrial can be between 150 to 250. However, most times we're going to be reading this off of the ventricular rate of that can be between 150 to 250 beats per minute. The rhythm is regular, so when you look at this and you take your calipers and measure from R to R, it's going to be regular, which can be different from an AFib RVR, which in that case would not be regular, or it can be too fast to tell that it is AFib RVR versus SVT. Is there a P wave before each QRS complex? Again, usually not discernible, especially at the high rate range, becomes hidden in the QRS. So SVT, the P waves are buried in there. What is the PR interval? Usually not discernible because, again, you need a P wave to measure that. Do all QRS complexes look alike? Yes, they do. And the length, this is a narrow complex tachycardia. The time is going to be 0.06 to 0.12 seconds. This encompasses all fast tachydysrhythmias in which the heart rate is greater than 150 beats per minute. Again, whenever treating this, make sure you're seeking expert consultation and decide what the doctor or provider might want to go in terms of treating this. Premature atrial contractions. This is another one of those instances where you want to look at what the P wave looks like. Is it uniform? Is it nice and rounded? Because again, if the energy is coming from a different impulse in the sinus, the sinoatrial node, it might look different than the other ones. So the rate in this is usually regular, but depends on the underlying rhythm. What is the rhythm? Irregular as a result of the PAC. So this rate, when this premature atrial contraction happens that causes another QRS complexes, this makes the rhythm irregular. So that's why you would never say that this is a normal sinus rhythm. Is there a P wave before each QRS? Usually upright but premature and abnormal shape. PR interval is going to be between 0.12 to 0.2 seconds. Do all QRS complexes look alike? Yes, they do. And the length of the QRS is 0.06 to 0.12 seconds. PAC is not a rhythm. It is an ectopic beat that originates from the atria. Normal beat just comes early. So this would be not a normal sinus rhythm with PACs. This would just simply be a sinus rhythm with PACs because it is not normal. So sinus rhythm with PACs. Coming into a first degree AV block, this is going to be our first block in the series of blocks. There's 3 of them. So again, using the 5-step method, what is the rate? We would count the amount of complexes that we see on this strip, either determining by counting the hash marks. In this case, there isn't any. Or you would just count from R to R and using the box method. The rhythm, is it regular? Oh, it is regular. The P waves are consistent. The QRS complexes are consistent. So this is regular. Is there a P wave before each QRS? Yes, there is. Are the P waves upright and uniform? Yes, they are. What is the PR interval? This is where we are going to get our information that tells us this is a first degree AV block. So if you look at the strip here, you'll see where the PR interval is prolonged compared to other rhythm strips that we've seen. So by definition, this is a first degree AV block because it is greater than 0.2 seconds, that PR interval is, or it's greater than 5 boxes. Do all QRS complexes look alike? Yes. What is the length of the QRS? It's a normal narrow complex QRS that is between 0.06 and 0.12 seconds. So the PR interval of greater than 0.2 seconds on ECG without disruption of atrial to ventricular conduction, the signal is slowed across the AV node. Definitely something we want to escalate to a provider, let them know if we don't know that the patient has a history of this. Here we are, we've come to our second degree AV block type 1, otherwise known as a Mobitz type 1 or a Winky-Bach block. The rate is going to be dependent on the rhythm. The rhythm here is regularly irregular. Is there a P wave before each QRS? Yes, does have P waves. However, there's that beat that does not have a QRS complex at the site of non-conduction. Are the P waves upright and uniform? Yes, they are. As we can see here, 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 and here. We see this P wave ended up not having a QRS complex, which makes it the Winky-Bach block. What is the PR interval? The PR interval in this case is going to be hard to give a solid number. One of the characteristics of the Mobitz type 1 or Winky-Bach block is the ever-growing PR interval before it's unmeasurable. Do all QRS complexes look alike? Yeah, except for the one that does not conduct. So whenever there's a QRS complex, it looks just like the other ones, except when it is not there. And the length of the QRS is between 0.06 and 0.12 seconds. The second degree type 1 AV block, specifically characterized by an increasing delay of AV nodal conduction until a P wave fails to conduct through the AV node. This is seen as progressive PR interval prolongation with each beat until a P wave is not conducted. There is an irregular R to R interval. The second degree AV block type 2. This is the Mobitz type 2. This is, however, not the Winky-Bach block. This is second degree AV block type 2 or Mobitz type 2. The rate is going to be dependent on the rhythm. The rhythm is regular when there are QRSs. Is there a P wave before each QRS? Yes, there is a P wave, however, there is no QRS at the site of non-conduction. Are the P waves upright and uniform? Yes, they are. What is the PR interval? For the most part, it is between 0.12 to 0.2 seconds. And do all QRS complexes look alike? Yes, except for the one that does not conduct. What is the length of the QRS? The QRS is 0.06 to 0.12. May be wide, greater than 0.12 if conducted from below the AV node. Second degree AV block type 2 is almost always a disease of the distal conduction system located in the ventricular portion of the myocardium. The QRS on the ECG will most likely be wide because the block occurs in the bundle of His or bundle branches, and conduction through the ventricles is slowed. So if you see this, there has typically been some damage to the SA node and the conduction is coming from somewhere else. Unlike the Winky-Bach block, there is no prolongation of the PR interval. It'll just see PR, PR, drop, PR, PR, drop. And our third degree heart block, or the complete heart block, the rate, the atrial rate and ventricular rate are independent of each other. The ventricular rate is slower than the atrial. The rhythm, the P to P is regular. So if you were to take a ruler or your calipers and measure all the P waves, you would see that they are pretty consistent. The same thing goes for the QRS complex. Take a ruler or a set of calipers and measure the distance between those, and they're going to be regular. The biggest issue is that they are not communicating with each other. So the P's are doing their thing, and the QRS complexes are doing their thing. Is there a P wave before each QRS? No. Are the P waves upright and uniform? Yes, they are. The PR interval is variable or really unmeasurable because we don't know which P wave belongs to which QRS. It's asynchronous. Do all QRS complexes look alike? Yes, they do. And when the QRS complexes are there, they are between 0.06 and 0.12 seconds. Again, they can be wide or greater than 0.12 if conducted from below the AV node. Premature ventricular contraction, or PVC. What is the rate? The rate of the atrial discharge is usually normal, as well as the ventricular rate is normal. However, it depends on the underlying rhythm. What is the rhythm? Depends on the underlying rhythm, irregular during a PVC. So because of that PVC being in there, this cannot be considered a normal rhythm. You would not call this a normal sinus rhythm with PVCs. You would call this a sinus rhythm with PVCs as long as those P waves are present. Is there a P wave before each QRS? No, because the PVC does not have a P wave. It is just its own impulse, wide and bizarre. Therefore, you cannot measure a PR interval. Do all QRS complexes look alike? It can vary. In the next slide, we'll cover PVCs of different focal patterns or morphologies. Do all QRS complexes look alike? What is the length of the QRS? Wide and bizarre. So this PVC is wide and bizarre. It's going to be greater than 0.12 seconds. However, the other ones look pretty normal. A PVC is not a rhythm, but an ectopic beat that arises from an irritable site in the ventricles. PVCs appear in many different patterns and shapes, but are always wide and bizarre compared to a normal beat. You can run into PVC patterns. Ventricular bigeminy would be where every other beat has a PVC. Trigeminy is where PVCs occur on every third beat. Quadrigeminy, PVCs occur on every fourth beat. And you can run into couplets. Couplets would be back-to-back PVCs. There's no normal rhythm in between or normal impulse in between. Two PVCs together is a couplet. And then you get into your spicy, kind of dangerous runs of VTAC. A run of VTAC can be considered 3 or more PVCs in a row. So if you come across this on the patient's rhythm strip and it hasn't been already addressed, make sure you're bringing that to the attention of your provider if the monitor room is not contacting you. The junctional rhythm. The junctional rhythm is junctional bradycardia is defined by this rhythm less than 40 beats per minute. A junctional rhythm would just be 40 to 60. Accelerated junctional would be between 60 and 100 beats per minute. Junctional tachycardia would be greater than 100. PJCs, premature narrow complex QRS with no preceding P wave. So this is considered a junctional rhythm because there is no P wave. This is coming straight from the ventricles or the junction. That's why we call it a junctional rhythm. And your definitions of sinus, Brady, and normal all are altered because Brady and normal in a sinus rhythm, those impulses are going to have different definitions. So when we're referring to junctional rhythms, if it's less than 40, that's a junctional bradycardia, where a sinus rhythm would be less than 60. So this is an example of our junctional rhythm. You can see here that there is no P wave to represent that. It is just a QRS. Accelerated junctional, it's the same thing, but faster. Junctional tachycardia. This rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 11 times 10, 110. It is otherwise irregular in nature. You can probably take your calipers and see that this is pretty consistent. There are no P waves here, and we're not going to measure a PR interval. And QRS. This is narrow complex tachycardia. It's between 0.06 and 0.12 seconds. Here are additional examples of junctional rhythms. This one doesn't have any P wave. This one has a retrograde P wave. Here's a junctional escape rhythm. Accelerated junctional rhythm. It's going to be a junctional rhythm. However, the rate is between 60 and 100. And then junctional tachycardia, again, same thing, just greater than 100 beats per minute. And your premature junctional complexes, it's going to be kind of like a PAC without the P, and it's not a PVC, it's just a PJC. Onto idioventricular rhythms. The rate of an idioventricular rhythm is going to be between 20 and 40 beats per minute. The rhythm is usually regular. You'll see this on your monitor pretty consistently. There are no P waves. The PR interval is not measurable because there's no P wave. Do all QRS complexes look alike? Yes, however, they are wide and bizarre, greater than 0.12 seconds, and with T wave deflection. Idioventricular arrhythmia is also termed ventricular escape rhythm. It is considered the last-ditch effort of the ventricle to try and prevent cardiac standstill. The SA node and the AV node have failed. The rate is usually between 20 and 40. So that you want to check on your patient, and you want to also confirm that this patient has a pulse. Accelerated idioventricular rhythm. So it's same thing as the previous one, except it's a little bit faster. This rate is going to be between 40 and 100 beats per minute. It's usually regular, no P waves. PR interval is not measurable. Do all QRS complexes look alike? Yes, and they happen to be wide and bizarre, greater than 0.12 seconds in time with T wave deflection. The accelerated idioventricular arrhythmia is considered the last-ditch effort of the ventricles to try and prevent cardiac standstill. The SA node and the AV node have failed. The rate is usually between 40 and 100 beats per minute. The agonal rhythm. What is the rate? It's usually less than 20. The rhythm is usually regular. There are no P waves. Therefore, the PR interval is not measurable. QRS complexes do look alike, however, they are wide and bizarre, greater than 0.12 seconds in time with T wave deflection. The agonal rhythm is when the idioventricular rhythm is less than 20 beats per minute or less. Frequently is seen as the last ordered semblance of a heart rhythm when resuscitation efforts are unsuccessful. Ventricular tachycardia. We can measure the rate on this by counting your complexes. VTAC, ventricular tachycardia, is going to be between 101 to 250 beats per minute. The rhythm, atrial rhythm, is not distinguishable. The ventricular rhythm, however, is usually regular. There are no P waves to tell on this, no PR intervals, with a wide complex tachycardia greater than 0.12 seconds in time. Ventricular tachycardia occurs when the rhythm in which 3 or more PVCs arise in sequence at a rate greater than 100 beats per minute. VTAC can occur in short bursts lasting less than 30 seconds, causing few or no symptoms. Sustained VTAC lasts more than 30 seconds and requires immediate treatment to prevent death, can quickly deteriorate into VFib. VFib, unlike VTAC, is not regular. The rate is not discernible, it's just chaotic. Rapid and unorganized, not discernible, the rhythm. Is there a P wave before each QRS? No, there's no PR interval. QRS complexes look alike. No, they do not. Ventricular fibrillation is coarse and fine, occurs due to multiple weak ectopic foci in the ventricles, no coordinated atrial or ventricular contraction. Electrical impulse is initiated by multiple ventricular sites. Impulses are not transmitted through the normal conduction pathway. Torsades, or otherwise known as ventricular tachycardia or polymorphic ventricular tachycardia, is a ventricular tachycardia. It's not beautiful like our regular VTach. This one's going to have different morphology, so it kind of changes. The rate is going to be between 150 to 250 beats. What is the rhythm? It can be regular or irregular. Is there a P wave? No. Therefore, we can't measure a PR interval. Do all QRS complexes look alike? They're wide. No, they don't. Then the length of the QRS is wide and bizarre, some deflection upward and some deflecting downward. Torsades is associated with prolonged QT interval, may terminate spontaneously, but frequently may degenerate into ventricular fibrillation. The hallmark of this rhythm is the upward and downward deflection of the QRS complexes around the baseline. The term torsades de pointe means twisting about the points. That is French. And this is our asystole. We can assume that patient is actually connected to the monitor. The clinical presentation may be the same. They're not breathing, they're apneic. You got your flat line on the monitor there. So there's no rate, there's no rhythm, there's no QRS, there's no PR interval, there's nothing. This is a ventricular standstill. Pulseless electrical activity. The rate depends on the rhythm on the monitor. What is the rhythm? May or may not be regular, depends on the rhythm. Is there a P wave before each QRS? Depends on the rhythm. What is the PR interval? Again, depends on the rhythm. And do all QRS complexes look alike? Depends on the rhythm. Electrical stimulation, however, the mechanics does not occur. The absence of palpable pulse and absence of myocardial muscle activity with the presence of organized electrical activity on the cardiac monitor. There's no pulse on the patient. Rhythm, there's just a rhythm on the monitor. So it's called pulseless electrical activity because you do see an organized rhythm on the monitor. However, there is no pulse. So if you see a rhythm on the monitor, it does not mean that the patient has a pulse, so always check, especially in an ACLS situation. Pace rhythms. Pacemakers are implanted to help control the heartbeat. They can be implanted temporarily to treat a slow heartbeat after a heart attack, surgery, or medication overdose. They can be implanted permanently to correct a slow or irregular heartbeat, or in some people to help treat heart failure. This rhythm strip on the top is a ventricular paced rhythm. This one is an atrioventricular paced rhythm, and this one's an atrially paced rhythm. You can see that for the ventricular paced rhythm, you have your pacer spike just before the QRS complex, initiating that. Here you have something for both the atria and the ventricle. And here you just have a strict atrial paced rhythm. You can see the pacer spike just before that P wave, and then the rest is normal QRS complex and T wave. An atrial paced rhythm. What is the rate? It depends on the rhythm on the monitor. What is the rhythm? So regular rhythm. Is there a P wave before each QRS complex? Yes. Are the P waves upright and uniform? Yes. What is the PR interval? It is between 0.12 and 0.2 seconds, may have a first, second, or third degree block. Do all QRS complexes look alike? Yes. And what is the length of the QRS? 0.06 to 0.12 seconds when following the P wave. So we got some abnormalities when it comes to our pace rhythms. This one is going to be a failure to capture. So you have your pacer spike, but it didn't really do anything. It's just there on your rhythm. It didn't capture. The risks of this are the pacemaker sends out an impulse but does not trigger a response. The signs and symptoms can be lightheadedness or hypotension. And then failure to sense. Um, you can see here that you have your P wave and then you have your pace or spike. And it's not a ventricular pace rhythm because the pace or spike is not before the QRS. So it's just not sensing. Signs and symptoms can include lightheadedness and hypotension. Failure to sense. The pacemaker sends out an impulse when not required. So yeah, this does not need to be paced because the patient has their own P wave and QRS complex. Failure to pace. Failure to pace. The pacemaker does not send out an impulse when pacing is required. Signs and symptoms can be lightheadedness and hypotension. So here, it's not doing its job. You see here the pacer spike goes off with the QRS, and then here you got this wide complex QRS that doesn't have any kind of pacer spike to it. And the ventricular pace rhythm. The rate depends on the rhythm on the monitor. The rhythm is regular. Is there a P wave before each QRS? The patient may be in atrial fibrillation or junctional, and no P wave occurs. What is the PR interval? Maybe in atrial fibrillation or have a heart block, first, second, or third degree. Do all QRS complexes look alike? Yes, those that are paced look the same. And what is the length of the QRS? These are wide, complex. It's greater than 0.2 seconds since it is created by stimulation of a ventricle. So you got your P wave is there, that's intrinsic, but it needs a pacer spike and you get your wide QRS complex. And failure to capture. You got your P wave here, but no QRS after it. So this P wave happened and then this QRS occurred. This P wave happened, however, no QRS happened, and this same thing goes here. The pacemaker sends out an impulse but does not trigger a response. Signs and symptoms can be lightheadedness or hypotension. Failure to sense. Again, this didn't, it's not doing anything. It's just kind of wandering in space. Failure to pace. This looks beautiful, looks on time. However, this pacemaker failed to pace. AV paced rhythm. So we have the situation where you have a pacer spike before your P wave and you have a pacer spike before your QRS complex. What is the rate? Well, that depends on the monitor. What is the rhythm? It's a regular rhythm because it's being paced. Is there P waves before each QRS? Yes. Are the P waves upright and uniform? Yes. PR interval is normal between 0.12 and 0.2 seconds. Do all QRS complexes look alike? Yes. What is the length of the QRS? 0.06 to 0.12 seconds when following P wave without pacing. However, when it's ventricular paced, they are greater than 0.2 seconds. Failure to capture. We have here on the AV paced rhythm, you got your pacer spike before your P. However, here no QRS complex occurred. This did fire off on its own, and then here the patient did not need to be paced. Failure to sense. Failure to pace. T waves. The T wave on the electrocardiogram or ECG represents typically ventricular repolarization. However, various waveform morphologies may present as an introduction of benign or clinically significant injury or insult to the myocardium. T-wave abnormalities such as the tall T-wave. Tall T-waves, also called hyperacute T-waves, can be an early sign of ST elevation, myocardial infarction. The morphology of the T-waves can begin to broaden and peak within 30 minutes of complete coronary artery occlusion, and thus may be the earliest sign of myocardial infarction on the EKG. Other common causes of hyperacute T-waves include hyperkalemia, usually narrow, base, and peaked, early repolarization, left ventricular hypertrophy, and acute myocarditis. Less common causes of prominent T waves include pre-excitation syndromes, pericarditis, and scorpion stings. The inverted T wave. Inverted T waves are associated with myocardial ischemia, although not specific for ischemia. If clinical history is suggestive of ischemia, further investigation is suggested. You can see here where the T waves are upside down. T wave abnormalities. So the ST segment is an interval between ventricular depolarization and ventricular repolarization. It is identified as the end of the QRS complex to the beginning of the T wave. Which brings us to our ST elevation. ST elevation, or myocardial infarction, otherwise known as a STEMI, is a very serious type of heart attack during which one of the heart's major arteries, one of the arteries that supplies oxygen and nutrient-rich blood to the heart muscles, is blocked. So we can see here that the ST segment is elevated here, 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 and here. They present on different leads in the ECG and can look different. But the takeaway is the ST segment is elevated. And ST depression. ST depression occurs when the J point is displaced below baseline. Just like ST elevation, not all ST depression represents myocardial ischemia or an emergent condition. There are multiple conditions associated with ST depression. Some of these include hypokalemia, cardiac ischemia, and medications such as digitalis. And we can see here, this kind of looks like ST elevation, except it's below the isoelectric line, therefore making it ST depression. You have reached the end of this lecture. Thank you for watching. Please proceed by attempting to take and pass the ECG rhythm interpretation exam provided by your unit educator or clinical coordinator. If further clarification is needed, please reach out to one of your clinical coordinators or educators for further instruction. Thanks for watching.